welcome to the show Healthy Living. I'm Kaylene Cornell, Health Education Coordinator for the Purchase District Health Department. Dr. Rankin from Family Allergy and Asthma has been kind enough to come back and continue our discussion of asthma since we ran out of time. In the last show we covered asthma. So asthma is a chronic or long-term disease of the airways. Asthma is not catching, of course, but it can run in families. You may go for several weeks, months, or even years without symptoms or signs of asthma. Then you may have a flare-up of symptoms. Even when you're not having symptoms, you still have asthma. It cannot be cured, but it can be controlled, and it also can cause lung damage that will last forever if it's not controlled the way it should be. Dr. Rankin, first of all, thank you for coming back today. And could you please just explain what happens during an asthma attack?
Well, due to inflammation that often is chronic, even with mild asthma, patients will have hyperreactive airways, so they will react to the environment in abnormal ways. And most of that is through two processes, but mainly bronchospasm. So when you have bronchospasm, the smooth muscles that are in the airways will constrict, and that will lead to symptoms of asthma. Okay.
All right. So when we have this going on within the lungs, and people are not able to breathe as normally as they normally do, what kind of symptoms would you see then?
Well, the four cardinal symptoms of asthma are, first you would think of would be wheezing. So like just when you squeeze a hose pipe and you can hear noises from that, you get the same type of phenomena when you constrict the airways. So you have the air going through and you hear wheezing. Cough is another predominant symptom. It can often be just a cough. And because there are cough receptors in the lungs. You get short of breath because the lungs are not as efficient, and therefore you become short of breath because you have to breathe faster to get the same amount of work done. Then there's a degree of chest tightness. So, and this can be episodic or on a daily basis, but it's a recurrent problem.
Sure. Because I know within even a day you could see changes. You could be breathing just fine, having no problem, and maybe have some of those symptoms, but it may just go to a severe asthma attack. And what would be symptoms that you would need to really, like 911, move quickly on?
Sure. Well, you first look at how fast the symptoms are coming on is one thing. Then if you cannot talk in complete sentences, that's another one. If you can't lie back before getting short of breath, and then especially in children, we have like nasal flare-in and chest retractions, or even central cyanosis where lips turn blue. Those are all very, very late signs, as wheezing is late. So a patient can develop a cough, a little shortness of breath. That can be an early warning sign, and so it can appear to come on suddenly, but the process is probably there, as you were saying in your introduction. The process is there, and something is tipping them over into having symptoms.
Sure. What's the first thing that someone should do when they see these symptoms?
Well, if they have the symptoms and they have a bronchodilator, that's one thing to get close by. The first thing to do is not panic. If you have an asthma action plan, to keep that handy. If there's an environment that you're in, like around cigarette smoke, or if you're allergic to cats and you're around a cat, so you remove yourself from the environment or the situation that may have triggered the symptoms. And then you use the quick relief bronchodilator, such as albuterol or levalbuterol or perbuterol, and with good technique, which takes preparation ahead of time. And the physician will tell you how much and how often to use, and that should work rather quickly. And if it doesn't, then you need to go to the next step, which either go in the emergency room or call for help.
All right. So how long of a period would you want, for instance, if a child does go into an asthma attack and they've used their inhaler, how long do you want the families to to kind of take care of it on their own before they call the doctor
Sure.
or call ER?
Well, a bronchodilator, when it's used correctly, either by nebulization or a meter dose inhaler, 75% of its actions are done in about 5 minutes, and it will peak in 1 hour and last 4 to 6 hours. So we try to be fairly aggressive, and then after 60 minutes, if things are not looking better, then that's when to make some type of decision.
Sure, yeah. And I know, like I mentioned earlier, you know, control is what it's all about, you know, so you don't get to that situation where you have to go into ER. We'd love to see no one having to go, you know, to the ER or have an emergency situation. There are different kind of medications, which makes asthma a little bit different than, say, another chronic disease. You know, usually it's more pill form, and that's the only route of medication that, you know, someone would take. But asthma, it's different. Do you want to mention the different, you know, different, I guess, ways to take the medicine?
Well, sure. Well, there's basically controller medications to help prevent, and then there's the quick relief. We used to call them rescue, but rescue implies like throwing out a life thing. You know, we don't want to get that far, have that perception, just to treat symptoms. So we call them quick relievers. We use inhalers because they are faster in onset. They work better and with fewer side effects. So we you know, whereas years ago we were using like albuterol tablets or albuterol syrup, we're using inhalers now for those reasons. Unfortunately, inhalers take technique, and they have to be done correctly to work, and that's one of the things that we look for if patients have poor control or not doing well, is are they getting it done correctly?
Sure.
Then we have a confusing array of different types of inhalers that make it even more difficult to treat. It would be nice if you had, you know, just one technique, and sometimes we can do that depending on the medications.
Right.
So technique is extremely important, and you have to go over that and review that constantly when you're not having an asthma exacerbation, because they're harder to use when you're short of breath. So that's not the time to learn. So you do that in advance. Technique is the two biggest problems that people have is they breathe in too late or too early, and they breathe in too fast. And that's the problem. The faster you breathe it in, the more hits the back of your throat, and then it doesn't do anything but cause side effects, and it's not effective.
Sure.
It's got to go slowly to go back down into the lungs. And even at best, 16% gets into the lungs, which is not a problem because they've adjusted the dose accordingly. So we use these spacers like we have here, and the spacer, you put the inhaler in on this side.
We have this kind of a sample one if you want to put it together.
So this is a meter dose inhaler, and this would go here, and when you discharge it, which this one's not going to do it actively, it blast into the chamber. The larger particles are going to be adhere to the side. The smaller particles are going to be in the center, and then that enables the patient to breathe slowly the small particles in. So it's a little bit difficult to go through the entire thing, but you would push out, and then within 5 seconds breathe very, very slowly until you take a full breath, and then you'd count to 10. And we always teach without a spacer because these things are rather large and people don't carry them. We don't all have purses to carry things with, and so we always teach without the spacer as well. But for an inhaled steroid, we're also trying to prevent side effects with it, and so this prevents a lot of the side effects like hoarseness, thrush that you can have a small amount of time with inhalers. So that's why they're important. Now we've got the little mask for the small children, and they're going to breathe in and out 6 times, after they're putting the 1 puff in. And some people say, well, I want to do 2 puffs, so I'll push it twice. No, it's push once, breathe once, that's 1 puff. And then, so if it's 2 puffs twice a day, you want to wait 30 minutes or 30 seconds in between, and then do the next puff. And you do have to wash these out once a week with soapy water. It decreases the electrostatic energy that can cause problems.
And they're easy to clean. I mean, they pull apart.
Yeah. Put them in a dishwasher. And they're latex free. So
now, do you want them when they use their spacer? Can they just breathe many times in there to make sure they get all the medicine? Whereas if it's just the inhaler, it's the 1 puff, hold your breath. But with the spacer, does it make a difference?
You can do that, but with good technique, usually it's just the 1 puff is enough. Usually. Yeah. Now there are also so that's with a meter dose inhaler. They used to have Freon or CFC, and now they do not. They have HFA due to the Montreal and Helsinki protocols. They either went to the HFA or dry powder inhalers. So some of the controller medications are dry powder, and there are examples of those, and there you have to learn the technique and so on.
Yeah,
and
this is
and so on.
We have one.
That's one. They're little bitty. I think they call them blistules, little blisters of things that these things break. So they would open that up and push this down. That breaks one, and it's just a little bit of dry powder that they're having to breathe out, and they breathe much faster with this to activate it, and then we have to try to get them to slow down a little bit even at that. Then they're taking that same slow, deep breath, and you don't want to breathe out into that breath because you don't want the moisture from your breath to interfere with the dry powder.
Sure.
And then even in humid conditions like a hot shower area, that it can be a problem. But I think the main thing is to understand the nuances of these inhalers, take the time to read the instructions that come with it, because they're very important, because if the medication's not getting there, it's not going to work. Now, you can take another puff, but you just add it to expense, and it's harder to interpret. So,
sure.
So it's not that easy, and we understand that, but it's the best way to treat.
Sure. Now I know with the dry powder, for ages, the inhaler is used more for younger, whereas the dry powder makes a difference as to you have to hold it more carefully. And do you prefer one over the other?
Well, I tend to use the meter dose inhalers if the patient's predominant symptom is a cough. I feel like that the dry powder can be a little bit irritating because none of this stuff is designed to go into our lungs. It's a medication, and especially when it's inflamed. So if there's a lot of coughing, I will tend to use a meter dose inhaler. And then it depends on the patient. Some people, if they're having trouble with, okay, is this my controller medication? Is this my a quick reliever? Maybe if they have a different technique, that would be easier for them to keep straight. If it's somebody that's having problems with technique, then I'm going to try to use one technique, and hopefully they can do that one correctly, and they can use that one technique for relief. So it just depends on learning the patient and learning what's going to work for them, and sometimes that does take time to know the patient.
Sure. Yeah. When you have, like you said, it's hard to carry the spacer. No one's going to carry that, spacer around, or the vortex. They're just too large. But the controller medicine is taken only once. So that could be just for their controller, and they just, leave it at home.
Well, some of them are twice a day, but your point's well taken. That's at home. They shouldn't really need to carry that. They can use the rescue and without the spacer. And even really you have an example of the Symbicort there, Dulera. The studies are done with them even without a spacer. And they have less oropharyngeal candidiasis, or the thrush, which is low incidence anyway, but they have less incidence. So even their studies don't even say to even use a spacer. Now, we continue to do so because we think it helps with the technique. But they shouldn't have to carry around the spacer. If you don't teach them to use what they're carrying around in their pocket, you'll lose.
Yeah.
You know,
Yeah.
so you have to teach them what they've got.
It has to be user-friendly.
And hopefully they've got that.
Sure.
Yeah.
Yeah. Yeah. What about schools with kids that they need, their medicine there? What do you recommend to parents?
Well, I can tell you that I started my practice in Paducah in 1988. And the level of care that the nurses and teachers are doing with asthma children now, and the coaches that are dealing with exercise-induced bronchospasm is just 1,000-fold better. They've just done a great job. And but it's an issue because you have different caretakers, and the children are of different maturity. Some of them, can take charge of themselves at a very young age, and some it takes a little bit longer. So there's no single age.
Right.
They have to be able to have access to an inhaler. Sometimes they can carry it with them. You have to make sure that they understand, that it's a medication, and and what it's for and what it's not for, and all of those things you have to do. So they have their inhalers and everything with their names on it, and there should be written, clear instructions on what to do and when and how to do it. Now, asthma is a very complex type of disease. It's not like, I'm not saying managing high blood pressure is easy, but you got a number, or hyperglycemia, diabetic. It's a number. People understand that. There may be a gray number, but if it's over X, you do Y. Asthma is a little bit more difficult. Things can occur suddenly, and it's hard for any level of professional, whether it's an intern, resident, attending, private physician, parent, or the patient. We all do equally at times poorly. It's a very difficult thing to assess. That's why we always try to peak flow meter. We're looking for other ways, like exhaled nitric oxide levels, things to improve our ability to predict outcomes. So when you ask, so if you give too complicated directions on those written protocols, that people can't follow them.
Sure.
And they won't. If you make it too simple, then it's difficult as well, because we're trying to do something in a simple way that people can understand in a process that really is not that simple.
Right.
So, but with experience, it's very well treatable and controllable. Looking at everything, but it's a difficult process. So we do our best with our written plans, but in the final analysis, it's going to be the awareness of the student and the attentiveness of who's in charge.
Sure.
And how well they do in getting things taken care of in a good fashion. And I worry a lot less now than in the past. So again, they do an excellent job.
That's great. They need to be able to have the tools, have the medication at the school. So that's so important for families to get that, fill that, medication and get it to the school, so the school nurses do have the medicine that they can help their children.
Sure.
Now, I know one thing with quick relief or the rescue medicine, some of them don't have counters. So how can you tell because you hear the spray even when it's empty. So how can you tell if there's medicine in the meter dose inhaler?
Well, fortunately, we do have two now that do have counters. There's Venon HFA meter dose inhaler and ProAir. ProAir just has a counter. So you know, it'll count down. Short of that, what we're supposed to do is tell patients to count the number of puffs and record it, count down to the 200, and that's difficult. It's easy to say, but it's difficult to do in practice.
Yeah.
You're right. Just because you can hear something shake around in there doesn't mean you're getting the full medication. Now, with a rescue inhaler, if it doesn't work, you just keep using it, you know. And for a controller medication, you have to keep better, you know, track of it best you can. I know the old days we used to float them and all this stuff in the sink, and it never was very helpful.
Yeah.
With the HFA products, it's not as difficult, and in fact, it may, the last puff, it may not do well, but you would know it if it's going to run out. So the older inhalers, that was more of a problem with the new ones. You know, you prime it when it's brand new. You know, spray it in the air 2 or 3 times. You'll figure it out, and then if it hadn't sat around 2 or 3 weeks, it's good that first puff. Yeah. And it should be fairly evident if you think it's working. It probably is with the HFA products.
Okay. Now, with this medication, they are steroids. So what do you say to the people who say, I don't want my child on it, I don't want them addicted, or I don't want to, you know, take it? What do you say to people about that? Well,
that's a very good question. We deal with it because if patients children are on inhaled steroid, the first year it can change the shape of the growth curve by 1.1 centimeters. But that's not every year. It's not cumulative. If they were to require it and stay on it past puberty, they have been shown to, in some patients, decrease it by about that same amount overall adult height. So if you have asthma and persistent asthma, we have to treat the inflammation. And the best way to do that is with an inhaled steroid. If you're in the emergency room, in the hospital, those are bad risk factors for lots of bad things. So we have to treat the asthma. Now, having said that, we do monitor it, and I always make the statement: use a dose that we have to. But use a dose that we have to. And the only way to tell that right now is just with frequent visits and in 3-month intervals. Then we say, okay, your control is great, so we're going to decrease the dose. And if we can get them down to moderate, mid-moderate, low-moderate doses or lower, then they'll be fine. Those that tend to fear medication side effects, if it's a correct diagnosis, for example, if they have 5 seconds of symptoms, it's going to take you 5 seconds to resolve it. 5 minutes, 5 minutes, 5 hours, 5 hours, 5 days, 5 days. And so oftentimes those that fear medication side effects and don't use their medications enough on the front end will end up on actually more later on as it snowballs, and then more oral steroids and so on. So you know, if they're getting 3 or 4 pulses of steroids a year, we need to do something else to prevent that. So it depends on where the child is. So we do assess it.
It is important to keep that, you know, medication, to keep the asthma in control, so you don't get into, you know, more trouble.
Right, because it's not just the severe asthma that has inflammation. Even in mild, when they've been able to study this, limited, but even in mild persistent asthma, inflammation is there, and it's there before the age of 6. So it's early and it's there, and so we just do all we can to prevent. So, but we do monitor it and so on closely.
Okay. So when you're talking about asthma, of course, the word triggers come up because that is a huge part in what starts an asthma attack possibly. Now there's irritants and allergens because asthma isn't always allergy related.
Sure.
Can you mention what are a few irritants that you would see that would create an asthma attack?
Well, there's really three, like a three-legged stool. Three things that are triggering and in some cases causing, you know, asthma. Irritants, as you say, allergens, another, and then viral infections is the third. And they tend to be all synergistic. So, for example, diesel exhaust particles can potentiate allergies, increase the allergy antibody IgE, and make allergens worse. And so those children who live closer to a large intersection will have more asthma and lower lung function than those who don't. So, so those irritants. And we do live in Kentucky. I'm very glad to be living here, but we do have a lot of tobacco smoke still, and probably the primary irritant that we deal with is still secondhand smoke, which can cause and trigger asthma and all kinds of problems, you know, there.
But you know, what would be like the number one allergen do you see? Is there one over another? Or?
The most prevalent allergen in North America in that realm is cat dander. Cats are a very strong allergen to dander. You can remove a cat, get a home ready for sale, do the cleaning, and that cat dander will be there for 4 to 6 months. There's an island that hadn't had a cat there in 40 years on the entire island, and there's still measurable cat allergen there, so it's very strong.
Wow.
And about 30% of the dander floats around in the air, so if you walk in, you can breathe it in. Then there's dogs. I don't like to pick on dogs as much, but they're there. And then dust mites, which are year-round, late summer and early fall, highly associated with allergic inflammation, allergic rhinitis, as well as asthma. And so those are, and then, you know, there are mold spores here, and they're year-round but worse in the fall. Alternaria is one that's associated with the fall-type asthma epidemic with severe asthma exacerbations in the emergency room, called alternaria.
And so that would be like in leaves or in the ground they find,
Yes. So those are the main ones. Of course, now we have very high pollen counts. And studies show that during pollen counts, ER visits and hospitalizations increase for asthma. So, you know, we're fixing to look at high pollen counts. It's already started, and it'll get worse for tree pollen and grasses. So, and then weeds. So all of those things can potentiate allergen inflammation and also trigger symptoms.
So hopefully with taking your medication and being aware of your triggers, using your asthma action plan like you've mentioned, are all important pieces. So there are 6 key steps if you can kind of think of, like we mentioned, you want to go see the doctor to get that right diagnosis and use your asthma action plan. If your child has one, take it to the school so the school nurse can use it. Of course, taking your medication as directed and making sure you understand that technique. And also telling your doctors what makes your symptoms worse. Maybe keeping a diary at home to say, well, or even on the calendar, well, this day this happened. There's many things that you can do, and hopefully you will be more aware of how you can keep your asthma in control. Thank you for watching our show today, and thank you, Dr. Rankin, for coming back. A lot of good information. Appreciate it.